Okay, so welcome everyone to the first, well, I suppose the first real clinical webinar of 2021. My name's Ian Green. I work for SNOMED International in a variety of roles. I'm the customer relations lead for Europe, but also head up the clinical engagement team. And we run these monthly clinical webinars. And tonight we're joined by Dr. Matthew Valentine and Olivier Karasira. I hope I pronounced your surname correctly. So Matthew's from Curate Health and Olivier's from the Sovereignty Network. And they're going to share with us some work they're doing really focused on the use of SNOMED in Africa. So Matthew, I'm going to pass over to you, and I'm going to be getting some questions ready. In terms of the way the session will run, so the presenters will run through the presentation for about 30-35 minutes, and then we'll have time for questions at the end. If you have any questions, please put them in the Q&A, which is at the bottom of your screen, and we'll address them at the end of the presentation. So Matthew and Olivier, over to you.
Great, thank you very much, Ian. And let me just get my screen shared here. So thank you very much for that introduction. Olivier and I are really thrilled to be here. And, we appreciate the invitation and the opportunity to present today. So it's 7 in the morning here on Thursday here in New Zealand. And thanks to everyone who's joining us today from wherever and whenever it is for you. I'm going to start by telling you a little bit about myself and about Olivier, and then we'll dive into the presentation. So I'm an emergency medicine doctor, and I live and work in the Bay of Plenty region of New Zealand. I'm from the United States originally, and I did my medical education and training there, and then moved with my family to New Zealand in 2008. For 11 years, we lived right across the street from this beach near the town of Whakatane, but alas, we moved from that house a couple of years ago. Now, you might not recognize the name of that town, but you actually probably all have heard of it. The little bump on the horizon right there is White Island, which is the volcanic island that erupted in December of 2019 while there was 40 tourists on shore. And that was quite a day in the emergency department. Anyway, after moving to New Zealand, I became very involved in clinical informatics, and I completed a postgraduate diploma in health informatics at the University of Auckland. And today I still work clinically, and I also serve as the clinical director of informatics for the Bay of Plenty District Health Board. But I also co-founded Curate Health, and I'm the Chief Medical Information Officer for the company. Olivier is joining us today from Kigali in Rwanda. It's a beautiful city that prides itself on its hills and its cleanliness. Olivier began his journey to health informatics from the education sector. He developed an education software platform in Rwanda that is able to generate real-time data for students' behavior, cognitive load, and health. And it was in that work that he realized the critical importance of good health for students, for them to be able to learn and achieve academically. And so as a result of that, he's now directing his efforts to bring the benefits of digitization to health in Rwanda, as he's already done for education. Now, Olivier is live with us, but to be on the safe side with his connection, we've got some, he's contributed to this presentation by preparing some videos that I'll be playing later, but it'll be available if I say anything wrong or for questions at the end. And we'll see more about his history as the presentation goes along. Now, in order to explain how this project has come about, I'm going to go back and tell a little bit of the story of Curate Health and how we've sought to implement SNOMED CT. Because without that history, it really won't make any sense of how our company from New Zealand has come to be working with Olivier in Rwanda to lead this project for community health workers. So the precursor to Curate Health was started in 2015 by our colleague Rohini Bana. Rohini is an experienced IT consultant, and she has a background in software implementations, business analyst, project management, and training. And she's been exposed herself to the consequences of the lack of a personal health record and cumbersome processes in the allied health sector in New Zealand. Rohini was very familiar with the gaps in the health system here. So she started with an idea initially to develop a new and improved patient management system for community allied health practices, but she quickly recognized that that market was already well served. She then focused on the lack of links between links of patient medical information from GP and hospital systems to allied health systems. She thought about all the healthcare providers out there, whom every time you go to one, you get a clipboard with a 2-page piece of paper questionnaire about your health history. Why can't there just be a digital version of that that you can share with whomever is necessary? And it was about that point she got some prescient advice from Alistair Kenworthy, who is in charge of the health information standards for the New Zealand Ministry of Health. He recommended that she utilize SNOMED CT and FHIR in her product. And despite those not being the established standards in New Zealand at that time, Rohini immediately grasped the potential what the potential could be to entirely structure all the data in a health app. So with that insight, she designed an app that both encoded all the information in SNOMED, and which was also very visually striking and easy to use. So symptoms and medical conditions, allergies, and even exercise activities were all coded in SNOMED. It was then all packaged in FHIR structures, as the app is built on AidBox, which is a FHIR platform by a company called Health Samurai. In 2018, Rohini and I were introduced by a friend of a friend. And the app at that point was a great proof of concept and was generating a lot of interest. And I'd been looking for an opportunity like this, and Rohini kindly let me hop on board. We refounded the company as Curate Health and charged ahead. The first version of the app had some back-end architectural issues, most noticeably the questionnaires and SNOMED ref sets behind it were hard-coded and not very flexible. We started efforts on a new version, and we developed a rules engine for SNOMED concepts. Basically, it can take an entered SNOMED CT concept, either specifically defined or range defined by an ECL query, and return to the user a set of questions about that concept or group of concepts. And the responses the user can enter are themselves SNOMED concepts, and thus they can trigger off a new sequence of rules and questions. Everything is still all packaged with FHIR structured data capture. So rather than developing big static forms, we can modularly define what questions we want to ask about a given concept. And the responses lead the user through any related questions, so we can gather a complete set of information. The user interface is set up like a chatbot to make it easy for the user to interact with and select options and fill in information. Concepts around the status of condition, dates, and etc. come from FHIR. And soon we found ourselves in mid-2020 and the world was in the depths of the COVID pandemic. It certainly slowed our plans and created new competing priorities. Although New Zealand had COVID pretty much eliminated at that point, precautions were still very much in effect. And it was around this time that we saw a link from ePatient Dave's blog and Twitter account about this video from Africa that won the People's Choice Award in the June FHIR Dev Days patient track. This was our introduction to Olivier, and the video describes how he'd begun working in health after a big project in local schools, during which he'd recognized the importance of health for school-age students. I'm only going to play a few minutes of the original, so the awkward cuts are my fault, not Olivier's. Nonetheless, I think you'll see why we were quickly entranced by it.
I recently used FHIR and SNOMED CT to achieve something that neither I nor medical professional and administrators I have spoken to know of having happened anywhere else in my home country of Rwanda, nor in the next door Burundi. Using a platform called the Sovereignty Network, I have shown that whether it be Uganda, Rwanda, or Burundi, we can bring together all types of data from different sources such as labs, electronic health records, and clinics, usually recorded on paper in Africa, and turn them into a global, interoperable FHIR and SNOMED CT health record, held under the patient's control, or parents' control in the case of school children. For the past few years, we worked on pilots, heavily on infrastructure and research. For example, 60 laptops, 60 tablets, 96 mobile phone and internet connection to deliver the platform. 2 schools in Rwanda and 1 in Uganda tracked student behavior, cognition, and health, including diseases, diagnosis, allergy, disability, etc., at school level. But we always lacked the ability to codify and share the health data efficiently, track it outside of school, and ultimately scale out through Africa, which is our dream. Further, we will be starting a collaboration between parents and schools to keep student health files updated and portable in the cloud with the best-in-class technology, such as FHIR and SNOMED CT. This is so much better than scraps of paper that get lost and destroyed. We desperately need better quality and more timely health data in Africa so that we can capture and measure outcomes. A school near where I live in Kigali has a student population of just 1,438, and yet the school clinic receives 5,850 visits per year, an average of 4 visits a student. Our journey focus is to support children and adolescents' well-being based on timely and accurate data, wherever, whenever it's needed.
After seeing this, Rohini and I immediately wanted to get involved with this project. Rohini is from South Africa, and I've spent a fair amount of time in Zimbabwe. So we both really felt compelled to see if our product would be useful, could be useful in Africa. But how to do it? Olivier was in Rwanda, and we were in New Zealand. The first thing we had to do was find out about the company the video mentioned, the Sovereignty Network. We went to their website and recognized one of the names on the list of advisors, Dr. Mike Bainbridge. Mike is a British GP, but has been resident in Sydney for many years. Mike's an internationally recognized clinical informatician and academic. He worked on read codes and SNOMED CT from their inception in 1984 and 1994, respectively. He formerly was a clinical engagement lead for SNOMED International. More importantly for us is we knew him. Mike had helped Rohini previously at an earlier stage of the app's development, and we'd all just met a few months earlier at the FHIR conference in Sydney in February, back when we could do such things. We got in contact with him and showed what Curate Health had created. He was quite excited and immediately wanted to put us in touch with the CEO of Sovereignty Network, Hamish MacDonald. We asked where Hamish was based, and Mike replied, Auckland. This was serendipity. Hamish is a Kiwi, but he got his start building medical software to serve clinicians and patients in Japan in the early 2000s. He founded and built the Diary Corp, now an Apple Enterprise Mobility partner, building best-in-class iOS healthcare solutions. Several large healthcare providers in Australia use the Diary as a virtual hospital and remote monitoring system to connect patients, caregivers, and clinicians. His passion is for people to be able to control and benefit from their healthcare data, allowing the data to flow where it needs to go, to whom it needs to go, and when it needs to go. After a whirlwind romance under this shared vision, we combined our companies and have set off to see what we can do together. Olivier celebrated by creating another short video that also introduces other members of our African team.
This is Olivier Karasira from Rwanda, Data Champion Lead for Sovereignty Network and your 8 Health. Guess what? Health has never been so simple. With my phone, I can record and share my personal details with my care provider with a simple click. Today, we are introducing the first and only end-to-end SNOMED and FHIR compliant forms with data champions in Rwanda, Burundi, and Nigeria, and help care providers to customize the form, the language, questions, and make the interaction with the patient so easy.
I'm Dr. Joanna. I'm a medical doctor from Nigeria. I'm a data champion with the Sovereignty Network and Curate Health. I help patients fill out their pertinent health records as regards their medical fitness, lifestyle, diet specifications, their medication, allergies, past and present medical and surgical histories, family and social histories, and any other relevant history. As a health provider, I believe patients can and should participate in their pertinent health record details, and it will simplify and make everything easy the way we relate with them using health technology.
Hello, my name is Pamela from Burundi, senior medical student and the data champion at the Sovereignty Network and Curate Health. Curate Health is not only helping me to collect details about the patient condition, but also bringing together all the concepts related to the patient condition. With just my phone, I can improve the outcomes of my consultations.
Hi, my name is Iona. I'm a physician from Burundi and also a data champion at Sovereignty Network and Curate Health. As my colleague mentioned, for me, the future in the health sector would be no more duplicate form, no more cross-checking of data, or no more manual transcriptions. Curate Health platform allows me to have remotely question and answers with patients, and I can customize the questions and the language for my patient to understand. Thank you.
So although our work continues in New Zealand for community allied health practitioners, we'll now turn our attention fully to Africa and Olivier's work in Rwanda. From its location in the very center of Africa, Rwanda has developed a reputation in recent years of being very digitally progressive in multiple domains. Innovations developed there readily spread across the rest of Central and Sub-Saharan Africa. As Olivier's original video showed, his entry into health was via this kind of digital transformation work in education. He seamlessly transitioned to health, where there are equally massive benefits that can be gained from digitization. Olivier has developed a relationship with the Ramara Health Center. It's the largest health center in Rwanda, based in the capital of Kigali. A large part of their work involves overseeing community health workers, a model of healthcare delivery that is well developed in Rwanda. The system initially started in 1995, and today there are over 45,000 community health workers in the country. Working on a volunteer basis, they provide services such as maternal checks and age-specific assessments for children. Each worker will be monitoring 100 to 150 families at any one time. Now, on average, these community health workers have only about 3 months of training, so their scope of practice is highly circumscribed and protocolized. As well, as I mentioned, they are overseen by doctors in health centers, and their protocols have a low threshold for referring patients back to the health center. However, they can treat and dispense medication for many common problems, such as malaria, diarrhea, and pneumonia. Currently, the workflow is entirely paper-driven with multiple forms and ledgers. And this video from Olivier demonstrates the scale of this paper burden.
Today, I would like to present to you how technology can support clinicians, community health workers on their workflow. Do you really understand their daily challenges? For this video, I would like to focus on community health workers' forms, family planning, pregnant women, delivery, child health forms represent more than 6 meters, more than 16 kilos to carry, more than 700 manual records. All that can fit here And the most important part, help the community health workers to deliver the right treatment.
Here's an example of just one of the most common forms for assessing a sick child. It's not the original, it's been translated into English. There is an identification section, an initial assessment section with red flags that mandate immediate transfer to the health center, a treatment and medication dispensing section, and a section about preventative care and counseling. Then when the community health worker reassesses the child in 2 to 3 days, there's a review section, again with red flags, a diagnosis and disposition section, and then a final advice and sign off. So although there's a lot happening on this form, you can see that the data structure as well as the workflow is pretty straightforward. Both everything on paper, that then collecting, consolidating, or analyzing information is practically impossible. So the process is ripe for digitization. So now we had both a great health digitization project and a flexible SNOMED CT and FHIR-based product to do it with. We just needed a partner to help fund it. As it turned out, SNOMED International was aware of what we were doing. They'd seen Olivier's original video in June of 2020 and were impressed. Hamish had gotten in touch with them at the time and spoke with them and applied for an international development license to continue the work that was seen in that video. SNOMED International later saw Olivier's second video in November of 2020. They were intrigued, so we arranged for a meeting and demonstration. They liked how we're using SNOMED CT in our product and shared our interest in using it to make a difference to healthcare in Africa. Currently, there are no SNOMED member nations in Africa and relatively few affiliate licensees. So both SNOMED International and us wanted to encourage further adoption of SNOMED CT on the continent. Projects like this will help demonstrate the value of SNOMED CT in an African context. Thus, with the support of SNOMED International, we are proud to announce Ijo Health. In Kenya, Rwanda, the local language of Rwanda, Ijo means tomorrow. The full tagline translates as better health today and tomorrow. Ijo will revolutionize the work of the community health workers, allowing stacks of notebooks and forms to be replaced with a single tablet, streamlining the work of the community health workers, their supervising doctors, and providing standardized digital data for healthcare planning and funding. Here's how the future could work compared to today.
inshuro zose eshatu wari wazipimishije? Yego. Ihangane muganga, mbwiye ko ambirasi ije, duhaguruke.
Using paper forms can be a long process. The patient history is important, but in our case, not easy to find. Archiving our books can take spaces we do not have. Bringing together our community reports is done manually. We must do it at the health center. Imagine carrying all these books.
My daily task is to supervise community health workers with their different activity and their report. It takes a long time to supervise their report and the different activities manually. After 15 years of experience working with community health workers, I recommend technology. Focus on facilitating analysis and reduce error from the report. Today, I needed to go through several reports before taking my decision. Sometimes that can delay my decision. Thank you.
Our country direction is to be fast and efficient. I would like to encourage Remera Health Center to adopt a paperless strategy and improve the communication between the community health workers, the health center, and the patients. That is why Remera Health Center is using SNOMED's terminology engine called Snowstorm. The Azure app, powered by Curate Health, is available on tablet, mobile phone, and desktop. Azure Healthcare solutions are based on FHIR for interoperability, and that will help us to reduce morbidity and mortality.
This is an early mock-up of how we are modifying our existing Curate Health interface for EJO. It reimagines that paper form we showed earlier as a digital process. The digitization process, including mapping all the items from those forms and workflows into SNOMED CT concepts and packaging it into FHIR structured data capture, will streamline the work of the community health workers do, facilitate the doctor's oversight of their work, and unload that massive amount of data that's already being collected, but which is currently confined to paper forms and ledgers. We'll be starting with child and maternity health, which is the main remit of the community health workers. But once established, the platform will be able to expand and to support additional patient groups and clinical workflows. There are, of course, multiple challenges and hurdles to this program of work, including the need to modify existing maternity and child health SNOMED CT reference sets for the Rwandan setting and matching them to current workflows. We really need to understand the community health workers' workflow and their paperwork so that with digitization, we can improve processes rather than just changing the format. We'll need to initiate an African-based SNOMED CT terminology server, as none currently exist. We'll need to adopt and add to the existing French language SNOMED CT synonyms. Although English has been adopted as an official language in Rwanda, French remains widely spoken. We'll need to create a Kenya-Rwanda set of synonyms as well. And in all these reference sets, we'll need to adopt and enhance a patient-friendly set of synonyms for presentation to patients and parents. Technically, we'll need to support online and offline work and data synchronization for locations with poor mobile data coverage. We'll need to have an interface to provide access to the record for patients and the parents of children through smart and feature phones. And finally, to be discovered. Undoubtedly, for a project of this size, we will encounter unexpected issues, but with our team and our technology, we're confident that we'll be able to overcome them. As I mentioned before, Rwanda really is an ideal country in Africa to demonstrate the power of technology like SNOMED CT. Regarded as a digital leader across Central Africa, success there will encourage uptake across the continent. The potential benefit to public health is immense. Governments, NGOs, and funding agencies will have an unprecedented depth, breadth, and timeliness of data, of health data for their populations. This will allow for efficient and rapid allocation of resources to areas of need, and the overall effectiveness for funding of health will be enhanced. The flexible and modular nature of the Curate Health software, powered by SNOMED CT, can also be used for a variety of other applications besides child and maternity health to bring these initial benefits to wider population groups. We're very grateful for SNOMED International's support of this project, and we've also submitted an abstract for the SNOMED CT Expo in October, and hope very much to be able to give the world an update on the project then. And thank you very much, and Olivier, are happy to answer any questions.
So thank you, Matthew, for that presentation. It's a really exciting developments on a number of levels. One, because of exactly what you said about Africa. So it would be good for SNOMED to make a difference in Africa. Also almost putting the patient central to the record keeping, I think is something we could learn from, certainly in the UK. My colleague has posted a number of questions, so I'm going to let him ask them. So Charles, Matthew, let me introduce you to Charles Guttridge. Charles, well, I'll let him introduce himself, but Charles works with me as clinical engagement lead for Europe, the Middle East and Africa. So Charles.
So am I unmuted?
You are.
And see, no, I can't put video on, so you can't see me, but yeah, so I'm Charles Guttridge. I was a hematologist, but I've retired from clinical practice. I am the Chief Clinical Information Officer at Barts Health, which is a academic health science centre in the east of London. And I've been doing that for some years now. And I suppose one of the things that kind of is moving about this is that much of our practice in East London is aimed at treating an amazing variety of people who've come from all over the world to settle in London and often settle in East London. And we certainly have big populations of African people who've come to settle in London. And as a hematologist, I was very familiar with looking after patients with hemoglobin variants like sickle cell and other forms of hemoglobin change and so on. As a younger doctor, many years ago, I worked actually in the West Indies in one of the islands in St. Lucia and got interested in how to use very basic digital systems then in beginning to collect data about patients. And one of the things I learned then, because the digital dream was still quite a long way away, was that it was perfectly safe. In fact, it was probably safer than using a hospital record system to just simply hand short notes of what you had done as a health practitioner to the patient or the mother, the child or whatever, to themselves, and just ask them to look after it and bring it each time they came to the clinics that I ran. And that's always inspired me in thinking about how to empower patients to use health data for themselves. And it's really encouraging to hear the story that Matthew and Olivier have told us about the part of Africa they're working in. But if I can get to my questions, maybe the first thing to ask is really, what kind of educational programs do you put in particular to help the community support workers to learn how to use the Curate software?
I think we have Olivier online now. Olivier, do you want to answer that question about the training for the community health workers? We're lucky that we're in more of a pilot stage at this point, but you're absolutely right. That will need to be rolled out as well. But I'll let Olivier address it.
Thank you very much, Charles, for the question. Can you hear me properly?
I can. Thank you very much.
All right. The idea is to integrate in the tablet videos teaching the community health workers how to deal with the condition they are, of course, allowed to deal with. I'm talking about malaria, I'm talking about pneumonia, I'm talking about diarrhea, I'm talking about fever, I'm talking about cough. Like today, this is the community health workers are dealing with that here in Rwanda. So we are integrating different videos available via the channel of our Ministry of Health, that is straight linked to the World Health Organization. We are also integrating in the tablets different PDF document with images, which will give a good guideline to the community health workers and all the algorithms that they need to give the drugs and pay attention on the age of the children and all those calculations they need before to give a drug. That's the first approach we are going to do.
Yeah, yeah, very interesting. And I think one that is very likely to work, actually. We know that in our systems in the UK, that putting online videos related to a particular function or a particular action, either through the HL7 info button or just as a set of training resources on a tab in the solution, is a powerful way of getting education over. So I think that sounds terrific, actually. Have you got to the point where you have to think about the governance of the system and how you're introducing new functions, or is it too early yet to have really developed that sort of process? And kind of related to that, how do you take account of ordinary citizens' opinions around the things that might be useful to them?
Yeah, that's a really good question, and you're right. We've not been doing this long enough to have established the formal governance, but in that African context, and we are very, Mike Bainbridge and I, who have been the main clinicians working from this side on it, are very aware that coming in from the US, New Zealand, Australia, UK to Africa and to determine what should be done is a recipe is arrogant and a recipe for disaster. So we're for that reason we've got great clinicians at the Ramara Health Center who they've been defining what the requirements are. We've got other clinicians in Africa working with us, as that second video from Olivier showed. And we are grounding everything against the World Health Organization guidelines for community health as well. So we think we have a good basis for those initial decisions. But you're absolutely right. What we don't have at the moment is a great outreach to patients and ordinary Rwandans who are getting care from the community health workers themselves. But we actually hope that this, by as you said, starting to put that information back into their hands, that will empower them to get involved with how the platform works, what information and data will be useful for them, and how we can best deliver it to them.
Yeah, fascinating. I do have other questions, but I'm going to, I noticed that there are a couple of questions in the Q&A bar, so it may be the easiest way is if I just read those out to you, either for you or for Olivier to answer, or both, I think. So the first one is from Christian, who comments that it's a great initiative, but the question is that what high-level strategy do you have in place to operationalize the pilot project into a funded government program which takes into account the plans for long-term impact, and how might you streamline those efforts with other development partners that are working in the sovereignty health area?
Great question, and thank you, Christian, for that. Olivier, do you want to describe that the project that or the process that Rwanda does for reviewing initiatives and the Dragon's Den that they run for that?
Yeah, sure. It's a cocktail of when we started this project, the first stage was to collect the community health workers forms, and quickly we understood that they are structured on it's a duplication of the World Health Organization structure. So we were very happy to understand that, and we also understood that slowly they are releasing. I mean, right now the community health workers is, as I told you, dealing with malaria, dealing with diarrhea, etc. But in the structure of the World Health Organization, you can see that the community health worker can also deal with more anemia, skills issue, skin issues. And how we are doing this, we are first of all, we are duplicating the old system, and slowly we are releasing what the country is assigning to the community health worker. But the system is ready with the entire workflow suggested by the World Health Organization. And slowly we release as the policy of the Ministry of Health is giving more power to the community health workers.
Thank you. Great, thank you very much. If I could pass to the other question from Andrew Kantner, or Kanter, sorry. A long question, and I'll try and summarize, I think, what Andrew is asking about. But Andrew says that he's worked in health IT in Africa for about 20 years or so. And one of his points is that the flavor of health IT, particularly in the developing countries such as yours, comes and goes, and some things sort of get high profile and then disappear. There's a sort of specific ask around this, which is there are a number of systems and open source solutions. He quotes OpenMRS, and which have been integrated to other mHealth tools, and connect to district health systems, and that there is a common data dictionary mapped to which uses SNOMED CT and maps to other standards like ICD-10. And his concern is that concepts that are particularly needed in this part of the world are not necessarily found in the mappings of or in SNOMED. And he asked very specifically that whether partners in health in Rwanda have been trying out the long-term implementations of these things, and would you, as a group, be prepared to share the work with a larger community of implementers in Africa? And I guess there's a sort of hidden question in that, which is how might you do that if you were interested in doing so?
Yeah, no, thank you. Thank you for that question, Andrew. It's a great question, really getting to the heart of the issues. Look, whether it's in Africa or whether it's anywhere else, we've had, no shortage of, through history, of people coming along with a technology standard and saying, this technology standard is going to solve all of our problems. When in fact we know that the change is much harder than that. As far as integrating with other systems, the entire reason that we use SNOMED CT and FHIR is because we want to be interoperable, and we want to work with systems that are already in place. We're not trying to replace any of that. And OpenMRS is something that we're looking closely at now. It is at use in the Ramara Health Center for their HIV patients. So it's definitely something that we want to work with. As far as sharing work with a larger community of implementers, I don't see why not. I think we would absolutely want to work with anybody who is on the ground, who can who's taking care of patients who our technology could help to benefit, to whether that's making the patient's lives directly better or making work easier for people who are caring for people there. So yeah, very happy to hear from and work with other people in this domain.
That's great. Thank you very much. Can I? One of the questions I was sort of pondering as you both talked us through this is just the question which I guess faces everybody trying to deliver systems. It is usually less of a problem, again, in countries with secure networks and so on. But what do you do when your networks are down? Do you just return to paper? Do you wait? Is there enough function in the standalone tablet or mobile to make it work reasonably well? Are there any issues like that about connectivity that you're thinking about?
Well, absolutely, and that blessedly is a problem for our developers and not me, because it is a difficult problem. But look, it's certainly not a problem that's confined to Rwanda or Africa in any sense. There's areas here in New Zealand that have poor data coverage that hinders delivery of cares and other services. So it is a technical challenge, one that we've recognized and are working on, and we consider it a necessary requirement that our software will have to meet to be able to, for the tablets and phones that are being used to store data that it's collecting, and be able to synchronize that back to any servers when a connection is reestablished. I mean, there's always scenarios you can imagine where there's complete failures that you might have to revert to paper. But our goal is certainly to make the digital solution as robust as possible for the realistic conditions on the ground.
Yeah. I feel your pain. We, as you say, we all have that from time to time. So I'm going to ask a question on the behalf of the mighty Alistair Kenworthy, but I'm not going to answer the question. I'm going to hand it to Ian. So Alistair very reasonably asks, what are the prospects of an all-Africa SNOMED license to enable innovation like this across all the countries of Africa? Licensing with SNOMED is always an interesting question, and one that fortunately I don't have to think about. So Ian, what do you say?
So I'd like to thank you, Charles. I'd like to thank Alistair from the bottom of my heart for asking. So the answer, well, firstly, I can't give you a direct answer to that question anyway, because it's not in my remit to do so. The one thing I would say about that question, though, is first of all, there is always, really ever since this organization, SNOMED International, and the IHSDO as it was previously, was created way back in 2008. We've always had a commitment, particularly with reference to Africa, to support SNOMED usage for humanitarian reasons. And that means essentially a free license, for the want of a better way of putting it. For the majority of Africa, that is the case, actually. So we effectively, most of Africa could get SNOMED on that basis. So you essentially get a free license in most countries, not all. I would agree with where I think Alistair is going with this. I do think there are a number of both discussions internally and larger projects outside of SNOMED that are occurring in Africa, which would prompt our board and our management board and the General Assembly to review the status of licensing within Africa. It's certainly something I know is we've had previous discussions about and will continue to do so. So my answer in a roundabout way, I guess, is watch this space. The one thing which I'd like to ask, which is kind of linked to that. So in my introduction to myself at the start, the one thing I didn't mention is the fact that I head up a lot of the genomics developments around SNOMED. And as such, I'm heavily involved with GA4GH, so the Global Alliance for Genomics and Health. And one of the members of that organization is the H3 network in Africa. So the H3 network is essentially collecting genomic samples and genomic data from all over Africa. It's a well-funded project, really, because a lot of the developments around genomics globally look to Africa as the cradle of civilization. So a lot of the genomic variants, I'll call them, from Africa have a huge impact on genomic variants elsewhere globally. The way you are collecting data and effectively the depth of data that you're collecting about patients, I would have thought would be extremely useful in that project, both in terms of the data you collect, but also the way you collect it is more to the point. So one, I'd ask, have you ever considered talking to the H3 network? And if you haven't, would you consider doing so?
Wow. So genomics is certainly something that we have considered, and frankly, that we consider to be one of the greatest reasons why we need to establish personal health records controlled by individuals for that most personal of health information that exists. And you're right, the potential power for that to, when combined with other sets of medical and social and demographic information, it releases huge possibilities for research, but also huge possibilities for abuse, discrimination, and other, and just exploitation that making that data owned by individuals and controlled by individuals, that will be an important safeguard for that. So I don't believe we've had any conversation with the H3 group, but we'd certainly be interested in speaking with them and understanding that work. And but yes, that's that our entire approach to this is that data should be ethically and legally should be controlled by individuals, so that if benefit is being gained from it, that everybody shares fairly in those benefits.
So I would agree with you. I think I suppose it's interesting the way the H3 network is set up. There are a number of sub projects. So in some ways you could almost dip your toe in the water in some ways. So the one that's been, I suppose, is the more recent development is something called CAFGen, which looks at TB and HIV. That may be a way of focusing it down slightly. I think the one thing about genomics data, so one is, I suppose, where I was coming from. One is the richness of the data you're collecting from the patient. So effectively the phenotype findings. because you have a great deal of information at your disposal. The other side, I suppose, to genomics is that if you're talking about tissue samples, you do need some kind of permission off the person to either take a bit of them or a bit of their blood or a bit of bone marrow. So I think that there is definitely a consent issue, but the consent around data sharing, I agree with you. That's a challenge. I won't call it a worry, but it's more a challenge, I think, for everyone, not just Africa. That's a global issue, and I would agree with you. But I certainly think the way you're collecting data, one would be very useful to that network in terms of the approach that you're taking. The other thing which I've been having other discussions with some of the people on that network is more, if you have this data in SNOMED format, you can then start to analyze it also in SNOMED format, and you can start to leverage then some of the ontological basis of SNOMED, which then opens up a lot of exciting opportunities.
Yes, absolutely. That ontological, those relationships are exactly what we do want to be able to use. I just wanted to make one thing really crystal clear about our approach, though. You mentioned that the richness and quantity of data that we'll have available to us. Just make it very clear that we are not making that data available to us. We are making that data available to the people about whom the data exists. We're not trying to be the Facebook of health or anything like that. Very, very much the opposite model. That data will be available for individuals who want to see their data or are willing to have their data used in that way. And we think a very compelling reason, we can make it very compelling for people to do so. But we are not collecting data for the sake of collecting data or for our own ends.
Thanks very much for that very comprehensive and interesting answer. Maybe I can sort of slowly move towards sort of rounding off the procedure, but I'm going to leave you in to thank you all very much. But could I just ask one last question, which is, this is a kind of a beginning statement, isn't it, that you've set out, and really interesting to hear. You've got some enthusiastic supporters in a small network of in the audience. And my question is, how could we as a group of people listening to your presentation help you over the next 6 months to a year?
Wow. So a lot of it at this point is work that I think a lot of people in this audience are, the fact that they're online listening to this or even watching it recorded later, continuing to push for the integration of standards like SNOMED CT in their own environments, in their own home systems and networks. That will have huge benefits for us all down the road. Now, I know I'm preaching to the choir here, but nonetheless, it's always good for the choir to have a pep talk. So as far as more specific things, we are at a stage where we're very focused on delivering this project in Rwanda, and wanting it and pulling out all the stops to make sure it's a success. I think once we've done that, the door really swings open then to and it becomes necessary to replicate that success elsewhere in the world. And we'll be very much looking for opportunities to do similar projects, not just in Rwanda, not just in Africa, but wherever it might happen. So people who think that this sort of approach might be useful for a project they're running, we'd welcome a chance to have a talk and look and see if that's something that we could facilitate. And you can tell already that with the geographic spread of our company, we are looking globally down the road, and we will be needing help globally from people scattered all over the world to help with projects and further deployments to really realize this dream of using the interoperability of SNOMED CT and FHIR to deliver really personalized care and personalized health records.
Great. Well, I think I think that my door and Ian Green's door are open through the SNOMED vestibule. Andrew Cantor, I think, who's actually left, has put up a little a short note saying that the Columbia International eHealth Lab, CL, and the Open Concept Lab are open as well, and making terminology services available to African and lower and middle income countries, in a sense, all systems a go. So really great to hear you. Really looking forward to hearing your advances at the Not Lisbon Expo. And I'm going to hand over to Ian to thank you very much for everything you've shared with us today, and also to thank Olivier. Thank you.
Thank you, Charles.
So
Thank you very much.
So I'd like to thank both of our presenters this evening, to Matthew and Olivier. I certainly think it's been very interesting and thought-provoking in some ways about where we go with some of these developments. We'll be running a clinical webinar next month. We'll be publishing the details either on snomed.org, on our website under events and the clinical web series, or I'm sure our communication team, as always, will be promoting everything on social media. So I'd like to thank our speakers again, wish you all well, and hopefully we'll talk to you in a month's time. But I'd like to thank everybody and have a good day. Take care.
Thank you, Ian.
Thank you. Thank you.